Thank you for having me here to this meeting. The first talk I'm going to give is atrial septal defects. I come from the Royal Brompton Hospital in London. Atrial septal defects, or ASDs for short, mean a communication between the atrial chambers. However, not all interatrial communications are atrial septal defects, and we'll see that more clearly very shortly. To start with, we need to know where in the septum is this defect and how that atrial septum is arranged. For a start, when you're looking at patients from anterior perspective, say an AP orientation, the atrial septum does not run directly front to back. In fact, it is more oblique in direction, about 65 degrees to the sagittal plane. You need also to look at the size of the defect, the margins of the defect, and what is the defect adjacent to. And very importantly, the aorta, because the atrial septum, or the plane of the atrial septum, abuts right to the back of the aorta. And this bulge into the right atrial chamber is termed the aortic mound. Now, if we take a heart and look into the right side of the atrium, as if we are in the right anterior oblique kind of orientation, we seem to get an impression that the atrial septum is very extensive. But in reality, it is not. The confines of the atrial septum is practically the floor of the fossa ovale and a little bit of the muscular rim around it. And we see that quite clearly when we make a longitudinal section like this through a heart, as we see here in a representative 4-chamber kind of cut. And we can see that atrial wall has an infolding superiorly as well as inferiorly, so that we have epicardial tissues interposing at the area that is commonly termed the atrial septum, whereas the true septum is confined to the thin area of the flap valve of the fossa ovalis or ovifossa. Now, there are various locations of interatrial communications. The true interatrial communication is just here, the so-called secundum ASD, which we will focus on. And there are many other locations that we have shown on this diagram here, such as the superior sinus venosus, the inferior sinus venosus, the vestibular defect, which is usually quite small, but sometimes can be big enough to warrant a device closure, and a coronary sinus defect. And this entity, the atrioventricular septal defect, we're not going to talk about in this session. We'll leave this for the following session. And I've put in the conduction tissues, sinus node and atrioventricular node, just for orientation and reminding people that some of these defects are pretty close to the conduction tissues. The most common is the secundum, or the ovifossa defect. And we'll focus mainly on this particular entity, and also we'll talk a bit about superior sinus venosus defect as well. So to start with then, we have the secundum. So-called secundum is actually a defect in fossa ovale due to a deficiency of the flap valve, so it has not completely closed off the communication between right and left atrial chambers. We're seeing it from the right atrium's perspective. Here's a coronary sinus and a tricuspid valve for orientation. It can take various shapes and forms, as we see in this particular specimen. The floor of the fossa ovale is fenestrated. So we have a deficient septum primum, in other words, with lots of holes in it, appearing somewhat like a fishnet, again for orientation, coronary sinus, and a tricuspid valve. This is another variation. We can see here, looking down there, we begin to see a floor of the fossa ovale. This is a very much a hole in the defect of the fossa ovale. And turning to the left atrial side, we see this much more clearly now. Here is the fishnet configuration, giving a kind of windsock form to this particular flap valve of the fossa ovale. By contrast, in this one, the flat valve fossa ovale has hardly ever formed. We see just a little rim here in the posterior and inferior margin of this heart, of this fossa ovale. We might note just a little hole at the bottom there. That is actually the vestibular defect, which is quite small in this heart. We see it here now, just there, but the main hole is dominated, is this ostium secundum, persistence of the ostium secundum due to deficiency of the flap valve. So we have a large defect, which, as you can see here, pretty close to the margins of the right pulmonary vein, especially the right upper pulmonary vein just there. So these defects can vary in terms of sizes, locations, margins, and forms. And I just show you 3 examples here. This is one that is located pretty high up. There's still a secundum ASD, and this is pretty low, pretty near to the entrance of the inferior cable vein. And this one, huge defect with very little anterior or posterior margins to anchor a kind of device, if you like. Now moving on to the superior sinus venosus defect, occurring in about 15%. It's quite high up, kind of a hole in the atrial septal plane. A big heart here, the thickened right ventricular wall. Looking into the right atrium tricuspid valve. Here we see the floor of the fossa ovale is intact. See the thin membrane here and the muscular rim around it? But way up here, the superior cable vein coming in, and here is the interatrial communication, well superior to the floor of the overfossa. So if you like, it's a high defect with the superior cable vein orifice sitting above the defect, sometimes the superior cable vein overriding that defect, and very often also associated with partial anomalous pulmovenous connection, as we see here, the right superior pulmonary vein orifice coming into the back of that superior cable vein. In this kind of malformation, it's important to bear in mind the proximity of the sinus node. As in the old publications, in the early repair of superior sinus venosus defects, surgeon tended to take an atriotomy cut through the region of the sinus node, which of course is not done at all since the early days. But just to compare a normal configuration of the atrial septum versus a superior sinus venosus defect, we have here the confines of the true atrial septum, the infolding of the atrial wall with the blue representing epicardial fat, and over here an interatrial communication, a superior sinus venosus defect, which is actually outside the confines of the true atrial septum and usually associated with anomalous pulmovenous connection of the right superior pulmonary vein. Now moving on to its counterpart, the inferior sinus venosus defect, which is far less common. Of course, it's near to the orifice of the inferior cable vein, as we see here. The specimen looking into the right atrium, here's the inferior cable vein just behind, coming through the eustachian valve, a quite tall eustachian valve guarding the entrance of inferior cable vein, and here's the defect. So the inferior cable venous return comes into the right atrium as well as goes underneath here into the left atrium. Now the coronary sinus defect, as we see here, at the mouth of the coronary sinus itself. The vestibular coronary sinus defect, as we see in this particular heart specimen, right at the mouth of the coronary sinus, but it can take a various forms as well, as we see on this chart. This is one that's right at the mouth of the coronary sinus, whereas in this entity, in this particular configuration, there are apertures or holes in that common partition that's made up of the coronary sinus wall and left atrial wall that allows communications between left atrium and coronary sinus, as we see in this particular example. Looking from the underside and from the back, that's the mouth of the coronary sinus, and these are the little perforations, if you like, connecting or opening into the left atrium. So it can take various forms. It's usually termed unroofing of the coronary sinus with varying degrees of unroofing, if you like. And finally, the vestibular defect, which are not that common, but the bigger ones have now been described in being amenable to device closure. So some examples that we see here, in these examples, pretty small. So the location of the defect is in the sinus part of the interatrial partition. So in summary then, we need to look at where in the septum are these defects, defect size, and importantly, bear in mind important structures nearby as well. Thank you very much for your attention.
I would like to thank you, Professor Ho, for the very nice introduction morphology presentation. And I think after that presentation, we could continue with the other speakers.
Okay, and congratulations, Krasimira, for this echocardiography congress again. We are really happy that we have you in the region. So, give me one moment. Okay, can you see my screen? Krasimira, we are okay?
Yes, perfect.
Okay, so I will try to be quick, and in the next 12 to 15 minutes, we're going to talk about how to assess patients for ASD transcatheter occlusion. And we need to know that atrial septal defects account for approximately 6 to 10% of all congenital heart defects, and it is the most common cyanotic congenital lesion. It is a defect that allows pulmonary venous return directly to the right atrium, and the most common symptoms are exercise intolerance, shortness of breath, arrhythmias, and right-sided heart failure. Depending on the size and the shunt, it may cause right-sided volume overload, pulmonary arterial hypertension, and arrhythmias. And most of our patients are diagnosed young, and most of them till the 5th decade of their life. These are the types of the defects. Ostium secundum is the most common one, and it is the one that I will mention in my lecture because it is the only one that can be managed with transcatheter devices. 1 year ago, we had the new ESC guidelines for the management of adult congenital heart diseases, and we need to know this algorithm. And very quickly, I will tell you that if we have a patient with ASD and right ventricular volume overload, then we need to check the WOODS, the pulmonary vascular resistance. If it is more than 3 but less than 5 WOODS, then we can proceed to transcatheter occlusion with an indication of 2A. If pulmonary vascular resistance are more than 5, then we need to give treatment for pulmonary arterial hypertension, and if it goes down, then we can implant a fenestrated device. If it doesn't go down, then we shouldn't occlude this ASD. What is the role of echo? First, to identify that a septal defect is present, we need to find the type of the defect, measure the rims and the size of the defect, assess the hemodynamic effect of this defect, dilatation of the right atrium and the right ventricle, see for any coexisting congenital cardiac abnormalities such as anomalous pulmonary venous return, guidance for transcatheter occlusion, and imaging post-repair. For ostium secundum, we need to know that first of all, we acquire images with transesophageal echocardiography from 0 to 90 degrees every 45 degrees, and if we need additional data, then we can demonstrate the atrial septum at every 30 degrees. We should measure all the rims and the defect size for possible transcatheter intervention. the rims should be more than 5 millimeters and ideally more than 7 millimeters, except for the aortic rim. And the size should be less than 38 millimeters, ideally for implantation of an occluder. We should measure the defect size with 2D and color Doppler echocardiography. We need to reduce the scale of the color in order to acquire low velocities, and we need to use pulse wave Doppler in order to assess the direction of the shunt. The septal length, the total septal length should also be measured, because if the occluder disc is more than 90% of the total septal length, this may cause erosion of the septum. The IVC, the inferior vena cava rim, is the most important, and we should know that, because if it is absent, then this is a total contraindication for transcatheter occlusion. And of course, we should visualize all pulmonary veins. So these are the projections that we use in conventional 2D transesophageal echocardiography. From 0 degrees four-chamber view to bicaval view in 90 degrees, we demonstrate the atrial septal defect. So in 0 degrees four-chamber view, right tilted, as you can see in my top right image, right tilted image, we can see the atrioventricular and the pulmonary venous rim. In short axis view, near the aorta, we can see the aortic rim, and at the opposite side, we can see the posterior rim. And in bicaval view, we can appreciate the superior vena cava rim and the inferior vena cava rim. We can use triplane views with 3D probe to demonstrate at the same time, simultaneously, all the rims of this ASD. And of course, we can use 3D and fast views of the atrial septum and the flexi-slice method in order to measure the minimum and maximum diameter of our ASD. 3D echocardiography helps us demonstrate the different shapes and sizes of ASDs. Here you can see a very small defect. Here you can see a aneurysmatic septum with a different shape. On our left bottom view, we have an oval shape ASD. 3D echocardiography is very important to show the size and the shape. And when we have debates between 2D and 3D, then with the newer probes, we can rely on 3D echocardiography, because we can align our views and find the exact maximum diameter of our ASD. Here you can see that we have 2D and color Doppler images of triplane views of a patient. This was the 3D and fast view where you can see that part of the septum was very mobile, right here. And then with 2D echocardiography, we measured the size of the ASD at 21 to 24 millimeters, while with the 3D echocardiography, we managed to find at the frame where the mobile septum was expanding, we measured the maximum diameter of this ASD at 29 millimeters. So we decided to implant a 30 millimeters occluder, and we were correct by using 3D echocardiography. There are a lot of devices, but the most common one that we use is the Amblager with the two discs, one larger left atrial disc and one smaller right atrial disc, and a waist in between, which goes and fulfills the ASD. And let's go to see some cases to understand which one should be suitable for ASD occlusion. So in this first case, you can see that with this transthoracic four-chamber view, we can appreciate that we have a large ASD atrial septal defect with bidirectional shunt. QP to QS was nearly 4, and you can see that we had the huge dilatation of right cavities with a D-shape of the septum. And we proceeded to transesophageal echocardiography. we saw that we had superior and inferior vena cava rim. Aortic rim, as you can see in short axis view, was absent, but we had the posterior rim. And in 0 degrees and 4 chamber views, we also didn't demonstrate atrioventricular rim. About sizing, 3D echocardiography showed that dimensions of this ASD were 4.4 to 4.1. And these were triplane views showing the absence of 2 rims. So this patient was not suitable for transcatheter ASD occlusion, as it was a very large ASD, more than 4 centimeters, and we don't have such large devices. We need to know that. The biggest one is 40 millimeters. This patient had bidirectional shunt with severe pulmonary hypertension and very increased QP-TQS, and we had absence of 2 rims. So this case is not suitable for ASD transcatheter occlusion. Another case that was managed with a transcatheter device, 18 years old female patient with palpitations, non-ASD. Her cardiac transthoracic echo showed dilated right cavities, normal left ventricular ejection fraction, 2p-TQS was 2, and elevated pulmonary systolic pressures. From transesophageal echocardiography, we can appreciate that we have present all rims, atrioventricular, pulmonary venous, aortic and posterior, and superior and inferior vena cava. 3D echocardiography showed that we had an oval shape ASD with the minimum and maximum diameter of 20 to 28. So we decided to implant our device, and going step by step, first of all, we advance the wire into the right atrium. We go through the defect to the left atrium with a stiff wire. Then we advance a balloon, because in our center we always proceed to balloon sizing for confirming the size of the defect. So in this case, we decided to implant an Ablazar occluder of 30 millimeters. If you remember, the maximum diameter measured by 3D echocardiography was 28 millimeters, and the balloon also confirmed this size. So we always go to the next bigger available device. First of all, we advance our device to the left atrium. We open the left atrial disc. We come back to the level of the ASD by showing all the time the short axis view, and then we open the right atrial disc, as you can see over there. And we check the rims from all sides that they are in between the 2 discs. We do this tuck test, which is pulling back the right atrial disc in order to check the stability and see if the device is going to embolize. Then we put some color Doppler to see for any residual shunt. And finally, if we are happy, then we release the device, and we have this final 2D and 3D images of this ASD occluder device. Another challenging case for ASD occlusion, 54 years old female patient, shortness of breath, palpitations, pedal edema, transthoracic echocardiography with dilated right cavities, ASD confirmed with TOE, QP-TQS was 2.1, we had dimensions of 26 to 15. We didn't have the aortic rim, but all other rims were present. Here you can appreciate again triplane views, and you can see this mobile part of the atrial septum. 3D and fast views of this septum, and in this right image you can see that I have increased the frame rate of my image, and I can appreciate the mobility of this inferior vena cava rim. So we proceeded to the implantation of the device. Again, our wire goes into the left atrium. We do a balloon sizing. Again, we were correct with the balloon, and we decided to implant a 28 millimeters Amblager occluder. First, we open the left atrial disc, and then we open the left, first the left, then the right atrial disc by using the short axis view. And then the interventional cardiologist relies on echo assessment, because from fluoroscopy he cannot understand if the apposition of the device is correct. So in this patient, the feedback that we gave to the interventionist was that from the inferior vena cava rim and the posterior side, both discs, the left and the right atrial disc, were above the septum, so we shouldn't release the device because it would embolize to the left side of the atria. And this is what we did. We repositioned the device, and we had this final nice result with all the rims between the two discs, and you can appreciate that with the triplane views of our device. And these were the first positioning where you can see even in 2D that both discs were above the level of the septum, and this was the final positioning of this device. And this was our final 3D acquisition. The patient came back for a follow-up visit. We always do a follow-up transthoracic echo, and we measure the volumes of the right cavities. Right ventricle usually decreases its volumes immediately after the implantation of the devices, and by 3D cardiography we can be very accurate in these measurements. And of course, showing very quickly, Krasimira, this case to show you just that we can implant devices in very large ASDs. This 18 years old female patient, again symptomatic with shortness of breath, palpitation, and pedal edema. QP2QS was 2.5. You can, sorry, let me show you these 2D images. You can appreciate the real enlargement of these right cavities in this young patient, and this huge ASD of 35 to 27 millimeters. So we decided to implant the 38 millimeters of Amblager occluder. One moment, please. So anyway, these were my last slides. We have some dysfunction of PowerPoint here, but anyway, in this patient, Krasimira, we had a nice result. And what I wanted to show you from these 3D views is that we need to see the proximity of the device to the mitral valve if we are going to implant a very huge device. So in concluding, you can see that heart team with interventional cardiologist and an imager with skills in 3D cardiography is very important in guiding these procedures and in appreciating patients with ASD. We need to rely in 3D cardiography. We need to measure the ASDs with 3D, in my opinion. And of course, we need to close those defects going only by indications. So thank you very much. Sorry about these last slides that do not play Krasimira. And I hope that I was in time.
Thank you, Kostas. Everything was perfect and amazing clinical cases. There is no question from the audience, I don't see. in a Q&A session, but I would like to ask you, which is the minimum length that we could have to implant this device for the ASD?
There is no minimum length. It depends on the enlargement of the right cavities, the volume overload. Because, for example, if you see a very small, for example, of course, we won't implant a device if the defect is less than 10 millimeters. Okay, this is something very small. But however, if you see a small defect, but you have volume overload, but you don't have available ASD occluder device, perhaps you can use a PFO device. You have options. But usually, I have never experienced a case to proceed to occlusion of this defect. So usually we occlude large defects that have volume overload in young people.
Okay, thank you, Kostas, for your contribution.
Thank you again, for the invitation.
Thank you.
Congratulations.
Professor Lee, do you have any comments or questions? I think
it's an excellent presentation. I just want to ask, you have beautiful 3D images. Are you be comfortable just mirror on 3D, not doing the balloon sizing it?
Kostas?
Is he left?
No, I didn't leave. I tried to fix my PowerPoint. So yes, I feel quite comfortable to rely on 3D echocardiography because I perform 3D every day, and my interventionist knows about that. And we have correlated balloon sizing with our 3D evaluation in more than 10 cases. And after he was convinced that with 3D we can give accurate measurements, then we usually don't perform balloon sizing anymore. But it needs practice before going to evaluation only by 3D.
Thank you.
Thank you. So we are moving for the next presentation. The first one.
It's 21 hours.
Kratonkov. Are you ready?
I hope it works this time. Congratulations to Dr. Papadopoulos. He showed very nice cases with severe dilatation of the right ventricle, and the other case with the two discs in the left. Do you see my screen now?
Yes. Perfect.
Yes?
Yes.
Can you give me feedback if you see my screen?
Yes. Yes.
Well, unfortunately, I see that problem with the, yeah, I think I can make it now. Okay, so I have nothing to disclose. And 20 years ago, we did not have guidelines to follow. And now we are happy that we have very, very nice guidelines. I would like to strongly recommend the guidelines of the American Society of Echocardiography and the Society for Cardiac Angiography and Interventions, because from these guidelines we can not only learn a lot about ASDs, but we can really follow them and make our lives easier. because a thorough echocardiographic evaluation of PFO and ASD includes detection and quantification of the size and shape of the septal defects, the rims surrounding the defect, and the degree and the direction of shunting, and the size of the cardiac chambers and the pulmonary circulation. So on this slide, we can see once again, after the beautiful presentation of Professor Ho about the types of ASDs, you can see the ostium secundum the ASD, which is the most common, and we can see it in 60 to 80% of cases. We can see the sinus venosus of SVC type, the inferior sinus venosus, superior sinus venosus type is always associated with partial anomalous drainage of the right upper pulmonary vein, and inferior is usually associated with anomalous drainage of the lower and middle right pulmonary vein. Ostium secundum ASDs are deficiency in the septum primum, and this is the most common form of ASD. Most of them, I would say more than 80% of ASD secundum can be closed percutaneously, and they can vary in shape and be oval or elliptical. And this is a diagram by Richard Harper, published in 2002, with the so-called optimal or ideal for interventional closure ASD and suboptimal ASD. You can see the rims of the defect, the rim to the SVC, to the inferior vena cava, to the coronary sinus, the rim to the aorta, and the distance to the tricuspid valve. On the second picture, you can see a very, very large ASD with multiple fenestrations in it. In 2006, Zahid Amin published a paper in which he suggested to call the rims SVC, posterior rim, IVC rim, the superior rim, the aortic rim, and also the AV valve rim. Ostium primum ASDs are within the spectrum of the AV septal defects, and we will not talk more about them here. Sinus venosus defects are not true ASDs, and they result usually from the absence of sinus venosus septum between the right upper pulmonary vein for the SVC type, or the middle and lower pulmonary vein for the IVC type. Coronary sinus defects or unroofed coronary sinus were beautifully presented by Professor Ho, and you had the chance to see them some minutes ago. A few words about atrioseptal aneurysm, which is defined as excursion of the septal tissue more than 10 millimeters from the plane of the atrial septum, or a total excursion of 15 millimeters. And PFO is not a true deficiency of the atrioseptal tissue, but rather potential space of separation between septum primum and septum secundum, and it occurs in about 20 to 25% of the population. PFO is defined by the demonstration of left to right shunting by contrast to color Doppler, and the stretch PFO is present when atrial hemodynamics have opened the foramen ovale and result usually in left to right shunting demonstrated by Doppler imaging. Right to left shunting may be possible in cases when we have increased right atrial pressure. Transthoracic echocardiography remains the preferred initial diagnostic modality for the detection and diagnosis of PFO, ASD, and atrial aneurysm. And in adults, this is the initial evaluation that we do. However, transesophageal echocardiography is required to further characterize the atrial abnormalities because transthoracic image quality will not always permit complete evaluation of the intra-atrial septum. These are the specific characteristics of ASD that should be routinely measured and reported, and you can see them in the guidelines. For the sake of time, I will continue. Transesophageal echo is not always required for assessment of a PFO if transcatheter closure is not considered, but transesophageal echo with contrast or transcranial Doppler is usually required to establish the diagnosis of PFO. In adults, TE can identify the margins of the rims of the ASD and assess the surrounding structures, the aorta, the caval veins, and pulmonary veins, AV valves, and coronary sinus. This is the time to tell you that we have learned from our experience that we always take decision about interventional or surgical closure of ASD after TE and never before, in order to be sure what is the best for the patient. Ideally, multiple views should be used to evaluate the size, shape, and location of the atrial communication and its relationship to the surrounding structures. You can see here, this is table 3 from the guidelines. And on the next slide, I have shown you apical 4-chamber view with a large ASD, parasternal short axis view with the aorta and the ASD. This is the color Doppler. And from subcostal view, we can see clearly the ASD. The TE protocol for imaging the interatrial septum also includes multiple and sequential views, which should give answers to all the questions we discussed already. And here you can see the so-called basal transverse, or similar to 4-chamber view at 0 degrees, short axis view with the aorta at about 45 degrees, the color Doppler, and bicaval view. Here it is 115, between 90 and 120 degrees. This is a picture of a patient who had been operated a long time ago, but she had 2 residual ASDs, which you can see clearly. We have closed this interventionally as well. Intracardiac echo has the advantages of the possibility to make the procedure without anesthesia, without general anesthesia, only with local anesthesia. And 3D transesophageal echo is giving us even more information. Here you can see a small round ASD, a small oval ASD, a large round, or a large oval ASD. This is a very good example that when we see 2D pictures, we can try to close this defect even with one device, but 3D clearly shows us that in this particular case, we have even 3 ASDs. So we should either send the patient to surgery or use more than one device. On this table, you can see the indications and contraindications for ASD and PFO closure. Right ventricular volume overload and significant left to right shunt with QP-QS ratio of more than 1.5 to 1 are the indications for ASD closure, and for PFO closure, cryptogenic stroke and evidence of right to left shunting. This has already been FDA approved. I will skip the contraindications for the sake of time and show you several pictures. This is a picture of a case with the left atrial disc and the waist of the device opened. The device is close to the septum. Here how it looks on the X-ray, and we can see here the device released and the echo picture of this. So my home take message is follow the guidelines, and I would like to thank you all for your attention. I hope next year I can show you the new wing of the hospital. Thank you very much.
Thank you, Professor Kratunkov. I am really happy for the nice presentation that you performed. There are also not questions. Do you want to make a short comment about any of the topics that you covered in your hospital?
About what?
A short comment about the patient, typically patient that you covered in your department.
In our department, we deal mainly with adult patients with congenital heart diseases. We also have children, but the biggest number is adult patients with congenital heart diseases. Some of them have been operated a long time ago. Some of them are newly discovered patients with congenital heart disease. The new cases are, most of them are ASDs. Some of them are ASDs, while operated patients usually include patients with tetralogy follow, coarctations operated many years ago, VSD patients which have been operated, and of course we follow a big number of ASD patients closed interventionally, because we usually close about 80% of ASDs interventionally nowadays.
Okay, thank you. Professor Lee, do you want something to comment?
I think the lecture is very comprehensive. I don't think I have more questions. Thank you very much.
Thank you. So, thank you, Professor Kratunkov, and we will moving for the next presentation, the last in this session. It's my pleasure to introduce Associated Professor Svetlin Tsonev. He will speak about the topic ASD when it's not so simple.
Dear colleagues, it's my pleasure again to be at that very exciting and full of comprehensive information meeting. As I know it's the end of the day, I'm going to be very short in my presentation. We already heard an excellent presentation about how to assess by echo atrial septum defect, but sometimes this task could be not so easy. And nowadays we know that adult patients with congenital heart disease are going to increase their number. So we should be ready to meet these needs to assess patients with congenital heart diseases by echo or other imaging modalities before, after, or just to follow up them without corrected congenital heart disease. Currently, we know that each in 100 birds is with congenital heart disease, and now we know that atrial septum defect, especially type secundum, is the most common atrial septum defect. It's about 8% of all newborn patients. We heard already about the anatomy of the septal defects. We heard a lot of information about the type of the defects and the progression of the hemodynamic and morphology changes in that patients. We should know that we already have a standard protocol for transthoracic echo assessment for ASD. And we know that if we follow up this protocol, it's very nice to guide even the interventional closure of the septal defects. We are sure that, for example, at subxiphoid short axis, sagittal, it's very nice position to assess the superior and inferior vena cava rim and atrial septum defect diameter to be measured. But we have the same protocols also for transesophageal echocardiography. Of course, sometimes the anatomy is not so simple. Sometimes we need multi-fenestration, especially of the primum septal defect. And you see that using the core Doppler could not give us so clear information about the fenestration, the direction of the blood flow, and so on. That's why it's very important to assess our patients in dynamics. You see that even the mobility of fossa ovalis is very important to make some conclusions about the direction of the shunt, or even to look for another fenestrations into the septum. Ostium secundum sometimes is very difficult to be assessed also, and you see on picture C, sometimes we have to use 3D or 4D echocardiography assessment. Of course, all this is very possible if we have a very good quality of the transthoracic, or in that case, transesophageal echocardiography. If we don't have the nice pictures and the nice echographic window, it's not possible to have a nice 3D assessment. Of course, 3D echocardiography could give us more information about the shape of the defects. If they are small or large, or if they are round or oval. Maybe this is very important to think about what is going to be our next step in treating that patients. Multiple ostium secundum, for example, is very nicely assessed by 3D echo, and you see that we could see from right or left atrial perspective to change the perspective during the this 3D transesophageal echocardiography. Very difficult for assessment is so-called unroofed coronary sinus, and here the 3D transesophageal echocardiography is very important, and you see here with the pointer that we could even assess or measure what is the size, what is the area of the defect at the roof of the coronary sinus. Of course, imaging for diagnostics or follow-up should be used, especially in adults with non-corrected congenital heart disease. For example, nowadays we know that ASD or PFO could be established by transthoracic echo. Of course, we should use transesophageal echocardiography or 3D transesophageal if we have some problems with the acoustic window, or we don't have enough information from the transthoracic one. Of course, imaging of transcatheter procedures is guided mostly by transesophageal echo or fluoroscopy, or of course, or intracardiac echocardiography. Nowadays we know that our colleagues from electrophysiology are much experienced in this due to the necessity to be very sure where is the puncture between the two atriums. Routine post-procedure follow-up should be given to the transthoracic echocardiography to our patients. Of course, the complicity again of the anatomy of the atrium and the complicity of the septum again should be very nicely and very precisely assessed. Here you see such called PFO with stretched PFO. On the right side of the window, you see that sometimes it's very easy to miss the defect, the ostium here. That's why sometimes it's very important to assess the patients after something like stress test, after physical activity, or after holding the breath, Valsalva maneuvers. Don't forget about this. What about the contrast echo? Of course, here again in transthoracic or transesophageal echo, contrast echocardiography has its place, and it has place even in transesophageal 3D echo. Here you see how nicely we could see the bubbles from the contrast or the saline that we use to assess if there is some shunt, or and is it very is it a clinically significant defect. Don't forget here also to use the transcranial Doppler to assess the bubbles if they go to the central brain systems. Now we are sure that this defect is really clinically significant. We have very nice guidelines that from last year, and we should ask the question, when should we go for another imaging modality for our patients that we are sure from the echo that we have ASD? The guidelines says that evaluation due to change in clinical status and or new concerning signs or symptoms should be one point to think about another imaging modalities. For example, you see here that contrast transthoracic echo may be appropriate, but transesophageal also, and CMR. About CT, it's relatively appropriate. Evaluation to determine the method of closure, for example, before the procedure, here you see that transesophageal echo has its very important place. And here we should be prepared to use this technique. Of course, if we have a very experience in CMR, it's also appropriate to be used for evaluation of the type and the type of the procedure of closure and the defect. Nowadays, we know that CMR is golden standard for assessing the defect, also the golden standard for assessing the rims of the defect and the possibilities for closure. But is it all in all cases, and do we have some other cases that even CMR is going to be not so informative. Here is one very nice publication almost one year ago, of colleagues that report of a clinical case when they find some formation into the atrium that is going especially into the right atrium. Of course, the colleagues goes to transesophageal echo, but it wasn't so informative. That's why they go for CMR. Again, they find something that is like a tumor mass, but of course not so sure about the vascularization of the mass. The question was it myxoma or it's something else? And of course, the truth comes with the surgeons and the follow-up histological assessment. And what they find that microscopy revealed organized thrombus with chronic inflammation and irregular fragments of collagenous connective tissue with endothelium on the surface with transition to extensive areas of fibrin deposition. So what was the case? The case was ASD with thrombus, chronic formation, and fibrin deposition in that patient. Of course, after the diagnosis, the ASD was closed in that patient due to the very high thrombogenesis risk. What about the modern techniques for fusion? Maybe we implemented them mainly to the needs of interventional procedures, but fusion may be used not only during the procedure. Here you see 3D transesophageal echo images fused with fluoroscopy. Here you see at each picture the orientation of the body of the patient. Here you see the transesophageal sound and the fusion with the 3D and fluoroscopy. What about planning the procedures? Nowadays we have so-called 3D printers, and using transesophageal images or CT images or CMR, it's possible to make a precise model of the atriums and of the defects. It's very important to plan what is going to be the strategy for the surgeon or the interventional cardiologist to close the defect. Here on the below the picture, you see the models that are 3D built in that case from 3D transesophageal echocardiography. Of course, that fusion could be used even in very complicity cases, for example, to guide percutaneous sinus venous atrial septal defect closure. It's very important. Here on the left, you see the 3D model to plan how to implant the stent that is going into the superior vena cava, and that stent to be very precisely implanted to close that venous atrial septal defect. So fusion imaging here is used for planning and for guiding the procedure. Thank you for your attention.
Thank you for nice presentation of Professor Tsonev. Professor Tsonev is not here for any comments, but I would like to give for the short comments Professor Ho, because she was in the beginning of this session, which is very important. Professor Ho, how do you think, how is it important to know very well the morphology of the structural heart disease to know how to proceed in our daily practice? and which is more important to do before we're starting to study the congenital heart disease?
Thank you for the question and thank you for having me. Well, before you start congenital heart disease, I always like to compare with the normal. So I think understanding, especially with the atrial septum, understanding the normal anatomy of the atrial septum is very important, not only in terms of device closure, but also for interventional cardiology, crossing the atrial septum, doing a transseptal puncture, for instance. So to know what the surrounding structures are, where are they, and how close are you to these various structures, I think that is crucially important before embarking on looking at the malformed heart.
I know that you're one of the pioneering of the 3D printing of the 3D dimensional defects, and you prepared very well the educational scenario in many countries. How do you think it will be possible during the 3D printing to cover this population of the disease, which is not very small amount of the people have these problems? Especially, I don't speak only for the ISD and VSD. I spoke about actually from the whole congenital heart disease. How important is the 3D printing?
I think you don't necessarily need to print, right? If you can have manipulation like you've just been showing, the speakers have just been showing, you can do the 3D modeling from your imaging. And from that, you can rotate around and see exactly where you are. So I think 3D printing is nice. You can have it in your hand, hold it, turn it upside down, whatever. But really and truly, 3D imaging is the key.
3D imaging, okay. Professor Lee, do you have any comments?
Thank you, Professor Hristov. I hope we have completed very full session today. I think although the ASD today we've gone through is a simple lesion, actually when you go into it, I find that it's not simple at all. Nearly every case I go to help them to do the device closure, we find problems. To an extent, I'm just afraid. I said, oh, what else? What is the difference? So often you go in prepared for one simple lesion, simple ASD closure, you may find multiple defects, or you may find anomalous pulmonary vein, or you may find the device, the septum is very difficult to cross. They can have a malaligned septum. So the more you look at it, the more you do, you find the ASDs is not simple at all. As for the 3D printing or 3D imaging, you can see it's become very important part of understanding congenital heart disease. They do give you the 3-dimensional, the real impression of the heart. For interventionists, they love the 3D printing. And now, you know, we started doing this sinus venosus SVC defect closure. I can see our interventionists do the 3D print for every single case. So they can put the devices in and they can look at it, whether it will block the vein or not. They can manipulate in their hand. It's much easier. Although you can look on the 3D imagings, I think with the fusion with the intervention, maybe at the moment is still very helpful for them, although it comes with cost. Thank you.
Thank you really for the nice comment. So I think I don't see any questions, but because we get a very long time this first session today, I would like to thank you all of our speakers, all of panelists, and Professor Hon, Professor Lee for all the good work that they do today, and to close this session. And tomorrow we will meet again at 6 East time or 4 o'clock in the London time, PM.
Yes.
And we will continue that program. Okay. Thank you so much. Have a good evening. Thank you,
everybody. See you tomorrow.
See you tomorrow.
Thank you. See you tomorrow.
Thank you.
Се обръщаме към най-сигурното нещо, което съществува. Науката. Науката може да пребори заболяванията, да открива лечения и да побеждава пандемии. Правила го е преди, ще го направи отново, защото когато се срещне с ново предизвикателство, науката не се отказва, тя атакува и задава въпроси, докато не намери отговорите. Това е силата на науката. Затова даваме тласък точно на науката и я развиваме. Нашите проучвания, експерти и ресурси, всички усилия са насочени към развитието на потенциални терапии и ваксини. Другите компании и академичните институции правят същото. Цялата световна научна общност работи заедно, за да се справи с предизвикателствата и всички ние използваме науката, за да помогнем това да се случи. Защото ако науката спечели, печелим всички.
More than 40,000 Teva employees who wake up every morning can be counted, as can the number of production sites in which they work around the world. What can't be counted is their motivation to enable someone, somewhere, to live better days with their loved ones. That's what counts. Teva provides 35,000 products to patients, more than any other pharmaceutical company. Every day, we deliver Teva medicines to pharmacies and hospitals in more than 60 countries. These are numbers we take pride in. But what really counts is our vast contribution to humanity. Our generic medicine saved hundreds of billions of dollars in healthcare costs over the past decade. We enable access for millions of people around the world to quality medicines. For over 100 years, Teva has pioneered scientific explorations, establishing 25 cutting-edge research centers and strategically investing in biopharmaceuticals to the benefit of current and future generations. Today, our innovation has led to more than 1,000 generic medicines being developed. These are all impressive numbers that can be counted. But what counts the most is the positive impact we make on 200 million people every day who can have access to a wider range of medicines to address their health needs. Cherish the priceless times together and live better days.